Welcome to Section 6 in Neurology. In this section, we will be discussing the basal ganglia and the dopaminergic pathways. So let's get started. So the basal ganglia is responsible for smooth, voluntary movements. It's composed of the striatum, which is composed of the caudate and putamen, and the lentiform, which is composed of the putamen and globus pallidus. It also has the substantia nigra, pars compacta, and the C for compacta. It also has the subthalamic nucleus, or STN for short. Now, the basal ganglia contains the direct pathway, which increases movement, as well as the indirect pathway, which decreases movement. So now let's show some anatomy of these locations. Here is a sagittal view of the brain. This is actually figure 8.4, which was discussed in section 1 of this chapter. What I would like to have you focus on now is the basal ganglia. As you can see, the caudate is here. It actually extends back and then curves forward again. And then we have the putamen, which, as this line indicates, is right here. And just medial to that is the thalamus, as you can see here. Now, the globus pallidus is actually medial to the putamen, and you can't really visualize it here. But if we were to take a coronal section of the brain and cut it through this portion, we would see figure 8.5. Figure 8.5 was also discussed in section 1 of this chapter. So now we can see that the caudate nucleus is located here, and that the thalamus is located here. And then of course we have the putamen right in this region, and then the globus pallidus externus, and then the globus pallidus internus. Now let's show a slightly more posterior coronal cut of the brain on a new slide. Since we are more posterior than in figure 8.5, shown in the previous slide, we can see the brainstem right here and the substantia nigra in the midbrain. As we will discuss later in this lecture, the substantia nigra plays an important role in the basal ganglia. As discussed in section 3 of this chapter, the red nucleus is also in the midbrain, right here and right here. That is the red nucleus. And we will discuss the relevance of knowing that the substantia nigra and the red nucleus are located in the midbrain once we get later in this lecture and discuss the dopaminergic pathways. So now that we have our landmarks, let's discuss the direct and indirect pathways of the basal ganglia. So on the left, we've demonstrated the direct pathway, and on the right, we've demonstrated the indirect pathway. It's important to recognize that both the indirect and direct pathways are on both sides of the brain, but for simplicity in this lecture, we will illustrate the indirect and direct pathways separately on separate parts of the brain. So now let's first discuss the direct pathway. So the direct pathway is the excitatory pathway, which means it increases movement. And the pathway starts in the motor cortex, which then stimulates the striatum, specifically the caudate and the putamen, at which point the neurotransmitter GABA is released, and then we'll see inhibition of the globus pallidus internus, which causes decreased inhibition of the thalamus, specifically acting on the ventrolateral nucleus. Decreased inhibition causes increased excitement of the motor cortex, which leads to increased movement. So let's draw this out. So we start up here in the motor cortex, which then sends signals to the striatum. So the caudate right here, and the putamen right there. The neurotransmitter released into the striatum is glutamate. Now this is an excitatory neurotransmitter, which is why these arrows are green, as in go. So now the putamen is activated, and it releases GABA, which acts on the globus pallidus internus, as you can see right here. Now GABA is inhibitory, hence the red arrow. Now the globus pallidus internus normally inhibits the thalamus by releasing GABA, specifically at the ventrolateral nucleus. We'll just write VL. The nuclei of the thalamus, which include the VL, are important, and they are discussed in the thalamus lecture of this chapter. So what's important to recognize is that because of the activation of the putamen, the globus pallidus internus is inhibited by GABA, which means that its effect is inhibited, which means there is increased excitement from the thalamus going to the motor cortex. So this is the gist of the direct pathway or excitatory pathway. The putamen has inhibited the inhibitor, which is the globus pallidus internus. So now let's talk about the indirect or inhibitory pathway. Now the indirect or inhibitory pathway decreases movement. So a signal starts in the motor cortex and then stimulates the striatum, the caudate, and the putamen, and then GABA is released, which causes increased inhibition of the globus pallidus externus, which then causes decreased inhibition of the subthalamic nucleus, which causes increased stimulation of the globus pallidus internus. And as we recall from the direct pathway, the globus pallidus internus inhibits the thalamus, so there is decreased stimulation of the thalamus, again acting on the ventrolateral nucleus within the thalamus. Greater inhibition of the thalamus means that there is decreased excitement of the motor cortex, which ultimately leads to decreased movement. So let's draw this out. So now we're focusing on the other half of figure 8.1 from your text. So motor stimulation comes to the striatum, as we discussed with the direct pathway, goes to the caudate, then it also goes to the putamen. And the putamen is stimulated to release GABA into the globus pallidus externus, which is clearly labeled on this left half. So I'll start it right there. So GABA is released, and the globus pallidus externus is inhibited. Normally, the globus pallidus externus inhibits the subthalamic nucleus, right here. So it would release GABA. However, with the stimulation of the putamen, which causes the inhibition of the globus pallidus externus, so the activity of the subthalamic nucleus is increased. And as you can see, there's a green arrow going from the subthalamic nucleus to the globus pallidus internus. And as we recall from the direct pathway, the globus pallidus internus actually inhibits the thalamus. So the point is that in the indirect pathway, the motor cortex has stimulated the putamen, which then inhibits the inhibitor of the globus pallidus internus. So the globus pallidus internus can be activated, which leads to inhibition of the thalamus, which actually means there is decreased stimulation of the motor cortex, and therefore decreased movement. So now let's talk about how to rock the basal ganglia questions on step 1. So the first thing you need to know is know the anatomical locations of each component of the basal ganglia, so namely the caudate and putamen. And also know the globus pallidus and the thalamus. On the left is figure 8.7 from your text, showing an axial cut of the brain. This was discussed in section 1 of this chapter. On the right is figure 8.5 from your text, showing a coronal cut, which we showed previously in this lecture. Now be sure to identify every element of the basal ganglia in each of these images. So on the left, we have the caudate nucleus right here. Then we have the putamen right here. We have the globus pallidus externus and globus pallidus internus. And on the right, we have the caudate nucleus right here. And we have the putamen right here. Then we have the globus pallidus externus and internus. Now with the sagittal cut of the brain, looking at figure 8.4 from your text, which was discussed in section 1 of this chapter, we can identify, once again, the caudate right here, which curves around, the putamen, which is right here, and then just medial to that is the globus pallidus, which would be in here, which is not easily visible from this perspective. So now let's talk about the other portion of rocking your basal ganglia questions, which is knowing the lesions. The first thing you need to know is that damage to the subthalamic nucleus leads to hemibolism, or hemibolismus. Next, know that damage to the striatum, or the caudate and putamen, leads to Huntington disease. Also, it's really important to know that unilateral lesions cause contralateral signs, and we'll explain what we mean by all of this. Here's the full image of figure 8.31 from your text, and notice that if you damage the subthalamic nucleus, you will cause dysfunction of the indirect pathway. So you will see signs of lack of inhibition, because remember that the indirect pathway decreases motor cortex stimulation, which decreases movement. So if you decrease the indirect pathway, you will actually increase motor cortex stimulation and increase movement, which leads to wild flailing movements known as hemibolismus. So remember, whenever you get damage to the subthalamic nucleus, you're going to get hemibolismus, which is the wild flailing movements. The next point is that unilateral lesions will cause contralateral signs. So on this side, we have the patient's left, and on this side, we have the patient's right. So if we damage any part of the right side of the basal ganglia, we would only get signs on the left side of the body. The reason is because the basal ganglia is responsible for modulating the motor cortex. And as you recall from section 2 on the spinal tracts, specifically regarding the corticospinal system, the motor cortex will send fibers through the internal capsule, which then decussate at the medulla. So damage to any part of the right basal ganglia will be manifest with left-sided symptoms. So the last point to make about the basal ganglia is regarding Huntington's disease. I will just write HD. Huntington's disease is a hereditary disease which damages the striatum, so both the caudate and the putamen. So this will damage both the direct and indirect pathways. After all, both the caudate and putamen are involved in both the direct and indirect pathways, as seen on this image. Recall that the indirect pathway is mainly inhibitory, while the direct pathway is mainly excitatory. So in Huntington's disease, we are affecting both the excitatory component of the basal ganglia as well as the inhibitory component of the basal ganglia. So damage to the indirect pathway will cause loss of inhibition, so we'll have decreased inhibition, which leads to the cortex being overstimulated, which results in the jerky movements known as chorea in Huntington's disease. Conversely, where the direct pathway is mainly excitatory and we actually have decreased excitement, patients with Huntington's disease will actually demonstrate that decreased slow movement. So the slow movement and these jerky chorea movements are both known to be in Huntington's disease. So let's do a question to apply this. So let's say a 27-year-old female patient presents with rapid involuntary movements in both arms. Now she was adopted and is unable to provide an adequate family history. From the image below, what region of the brain is likely damaged? So here we're looking at the basal ganglia. So with these symptoms, and given the fact that we know that because of the question stem, our patient has something wrong with the basal ganglia, we should be thinking of one of two things. First, Huntington's disease, and second, hemibolismus. So the rapid involuntary movements should make you think of the chorea in Huntington's disease. So since we are thinking about Huntington's disease, we would think that the striatum is damaged, so the caudate and putamen on both sides. Now, the reason we're not thinking it's hemibolismus is because if this patient had hemibolism, we would see more of a wild flailing on one side of the body, which is really not what we're seeing here. However, if we were thinking this patient had hemibolismus, we'd be thinking of damage to the subthalamic nucleus. And it would have to be in both sides because this patient is demonstrating symptoms in both arms. But again, that's not what this patient's demonstrating, so we're thinking it's Huntington's disease. So now let's talk about the dopaminergic pathways. So now the dopaminergic pathways project axons to various locations in the brain to deliver dopamine. Now there are four major pathways: the nigrostriatal, the mesolimbic, the mesocortical, and finally the tuberoinfundibular. Now this is figure 8.32 from your text, which shows all four dopaminergic pathways. We are going to go through each pathway on this image one by one, so don't worry about memorizing it now. For now, just focus on the midbrain. If we took an axial cut of the midbrain, like this, we would see figure 8.16, which was discussed in section 3 of this chapter. Notice how we can see the ventral tegmental area and the substantia nigra. The ventral tegmental area houses the cell bodies for the mesolimbic and mesocortical pathways. And the substantia nigra houses the cell bodies for the nigrostriatal pathway. If you remember these two areas, the ventral tegmental area and the substantia nigra, it will make understanding the dopaminergic pathways so much easier. So let's start with the nigrostriatal pathway. So the substantia nigra is divided into two parts. The part we're concerned about is the pars compacta, hence the C in this SNC. Now this releases dopamine, which travels to the striatum, so the caudate and putamen, hence the term nigro, as in substantia nigra, and striatal, as in striatum. Now dopamine stimulates the D1 and D2 receptors found in both the putamen and the caudate. Now when the D1 receptor is stimulated, it causes the excitatory pathway to be stimulated, which leads to increased movement. Now the D2 receptor stimulation causes the inhibitory pathway to be inhibited. We've inhibited the inhibitory pathway, which also leads to increased movement. In other words, the nigrostriatal pathway stimulates movement via the basal ganglia. So now let's look at our image of 8.32. So here we have the substantia nigra in red. We're going to follow the nigrostriatal pathway, which starts here in the midbrain. Recall this is the midbrain area, and it goes all the way up until it reaches the striatum in this area. Now let's look back at figure 8.31 to apply this to the basal ganglia. So the nigrostriatal pathway can stimulate the D1 receptors to stimulate the excitatory pathway. So there are D1 receptors in the caudate and the putamen. So the substantia nigra on both sides will stimulate the direct pathway by stimulating the D1 receptors, which causes increased activity of the direct pathway. At the same time, dopamine stimulates the D2 receptors, which are also in the caudate and putamen. Now when the substantia nigra stimulates the D2 receptor in the inhibitory pathway, it will cause decreased inhibition. So in other words, we will have decreased activity of the indirect pathway. So ultimately, the nigrostriatal pathway leads to increased movement. So now let's do a question to apply this. Now what symptoms would you expect with damage to the substantia nigra? Okay, with damage to the substantia nigra, there would be loss of stimulation of the D1 and D2 receptors. Therefore, there will be less excitement of the basal ganglia and the motor cortex. So the patient will present with decreased movement, or specifically, slow movement. So what we are talking about here with damage to the substantia nigra is Parkinson's disease. So we can expect all of the same symptoms of Parkinson's disease, including poor posture and tremors, which we can attribute to lack of stimulation of the D1 and D2 receptors in the striatum. So now let's talk about the mesolimbic pathway. In the mesolimbic pathway, the ventral tegmental area, which is in the midbrain, releases dopamine. The dopamine then travels to the nucleus accumbens, which is a part of the limbic system. And it also travels to other structures within the limbic system. So it can be easy to remember what the mesolimbic pathway is when we remember that the midbrain is also called the mesencephalon, as in meso in mesolimbic. And since we're dealing with the limbic system, we get the term limbic in mesolimbic pathway. Now the nucleus accumbens is the reward center of the brain, and it's associated with drugs, addictions, food, sex, and other things like that. And when you have hyperactivity of the nucleus accumbens, you get the positive symptoms of schizophrenia, which include delusions and hallucinations. Now the mesocortical pathway is very similar in that we can remember that it begins in the ventral tegmental area, which is in the midbrain, which is also called the mesencephalon, as in meso for mesocortical pathway. And just like in the mesolimbic pathway, the mesocortical pathway has dopamine, which travels to the prefrontal cortex, hence the term cortical in mesocortical pathway. Now the prefrontal cortex is responsible for motivation, emotion, and executive functions. And when you have decreased activity or hypoactivity of the mesocortical pathway, you get the negative symptoms associated with schizophrenia, which include flat affect, anhedonia, avolition, and other things. So now the last pathway is the tuberoinfundibular pathway. In this pathway, the hypothalamus releases dopamine, which travels to the anterior pituitary, which then inhibits the release of prolactin. So if you have dysfunction of this pathway, you're going to have decreased inhibition, which causes increased serum prolactin. And when you have hyperprolactinemia, you will get decreased libido, galactorrhea, and other things. So now looking again at figure 8.32, we have the tuberoinfundibular pathway going from the hypothalamus, right, in this region, to the anterior pituitary. And as we mentioned in the previous slide, when we damage the tuberoinfundibular pathway, we get decreased dopamine, which causes decreased inhibition of prolactin secretion, which of course leads to hyperprolactinemia. For more information about prolactin secretion, please watch the endocrine chapter. So now let's review all of the dopaminergic pathways together. Recall that they all project axons to various locations in the brain to deliver dopamine. And there are four major pathways. The nigrostriatal, which goes from the substantia nigra to the striatum, and if you have destruction of this, you get Parkinson's disease. And the mesolimbic pathway goes from the mesencephalon or midbrain, specifically the ventral tegmental area, to the limbic system. And when you have hyperactivity of this system, you get the positive symptoms associated with schizophrenia. And the mesocortical goes from the ventral tegmental area to the prefrontal cortex. When this is hypoactive, you get the negative symptoms associated with schizophrenia. And finally, as we just reviewed in the previous slide, the tuberoinfundibular pathway is responsible for inhibiting the release of prolactin. So when it's hypoactive, you will get hyperprolactinemia. Now, if you can remember these four pathways, their locations, and what happens if they are dysfunctional, as written here, you will do quite well on any question you get regarding these pathways. So let's just do one last question to review. What pathway is affected, causing a flat affect in a schizophrenic patient? So to answer this question, you just need to think about what dopaminergic pathway is responsible for emotion and motivation. Now that would be the prefrontal cortex. And that means that we're dealing with the mesocortical pathway. As you recall, the prefrontal cortex is responsible for emotion and motivation. If you have dysfunction of this pathway, you're going to have decreased emotion and motivation, which gives you those negative symptoms associated with schizophrenia. As a side note, recall that when dealing with the mesolimbic pathway, here in green, when you get this hyperactive, you're actually going to get increased activity of the limbic system, including the nucleus accumbens, which causes those positive symptoms associated with schizophrenia. When you have a problem with the nigrostriatal pathway, or damage to the substantia nigra, you're going to get Parkinson's-like symptoms, or Parkinson's disease. And when you think tuberoinfundibular problem, think hyperprolactinemia. And that concludes this section.